again. Okay. So I'm going to review thromboembolism in pregnancy, and it was a kind of a good review because I completely forgot all the cascades and all the clotting pathways and everything. I'm not going to go into that too much, mainly just focusing on diagnosis, management, and prevention. So this is mostly going to be from the ACOG Practice Bulletin number 196. And let's see, sorry, I'm just distracted by this. Okay. So venous thromboembolism is one of the leading causes of maternal mortality in the US, making up about 9% of maternal deaths, with a prevalence of 0.5 to 2 per thousand pregnant women. And just being pregnant and being in the postpartum period, there's a 4 to 5-fold increase in the risk of thromboembolism. And 80% of these are venous. So venous thromboembolism is DVT and pulmonary embolism. And you can see the breakdown there. About up to 80% of cases are DVTs, and then the other 20-25% are PEs. Half occur in pregnancy and half occur postpartum, with the greatest risk postpartum being in the first 1 to 3 weeks after delivery. Oops, sorry, that was duplicated there. So what kind of physiologic and anatomic changes can occur that increase the risk during pregnancy? Well, you're at a more hypercoagulable state. There's increased venous stasis, decreased venous outflow. The IVC and pelvic veins are being compressed by the gravid uterus, decreased mobility, and then there's something called the May-Thurner anatomy syndrome, where basically you're going to have compression more proximally involving the iliac, and it's more on the left, from the left iliac vein. By the gravid uterus. So these are the changes in the coagulation factors that occur during pregnancy. You can see up at the top there, fibrinogen is increased, as we know, factor 7, 8, 10 von Willebrand's, and then for the anticoagulants, protein S is decreased. So when you're seeing patients in the clinic and you're getting a history or on admission, you want to ask about history of thrombosis, DVT, or PE. That's the most important individual risk factor for the patient. The risk of recurrent thromboembolism in pregnancy is 3 to 4-fold. And the RCOG actually recommends repeating the assessment on admission, or if the patient develops complications such as pre-E, which I don't do, but maybe I should start doing it. So there's no widely accepted scoring system. The different committees and organizations kind of have different ways and protocols of doing it, but there's no one widely accepted system. And thrombophilias, whether it's acquired or inherited, is present into 20 to 50% of women who experience thromboembolism during pregnancy or the postpartum period. Okay, so without looking, how do you work up women with a history of thromboembolism? Michelle, because you looked at me. Uh-huh. Do you want to do any testing?
Before asking them questions?
Well, if you think that they might, that they might be at risk.
Yeah, we can get the sensor testing like we can genetic.
Which one?
Like factor 5.
Factor 5 Leiden. Uh-huh. What else? Anticardiolipin. What else? Lupus anticoagulant. Uh-huh. Antiphospholipid. Yeah. So the testing for the thrombophilia is good. And the reason why this is important, as you'll see later when I get to this very big, busy table, is it may change the recommendation for either antepartum prophylaxis or postpartum prophylaxis. So how do you diagnose a DVT in pregnancy? So over 80% will present with pain and swelling of the extremities. And, so if you see a patient who comes into triage and she's complaining of pain in her leg, right? And she says that one leg looks bigger than the other. So how do you do your physical exam so you can compare one calf to the other? Calf circumference, yeah. So you're gonna grab your measuring tape, right, and measure their circumference. So if there's greater than 2 centimeter difference, then that's suggestive. And then you're gonna order what test? Ultrasound, yeah, lower extremity Doppler. If it's equivocal, they say you could get an MRI. And then we know D-dimer is not useful in pregnancy, so we don't order that. Okay. How do you diagnose a PE in pregnancy? What do patients usually present with? What are the symptoms? Tachycardia, chest pain, shortness of breath. Okay, good. And then, so what studies, what are the 2 studies? I mean, it's written there for you guys, but what are the 2 studies that you could order? Or CT angio, right? And how do you counsel the patients about the imaging when they're worried about exposure to the fetus, radiation exposure to the fetus?
Well, VQ scan would be safe.
VQ, yeah, has less exposure.
CT angio, like risk versus benefits. If there's a high morbidity, if you have an actual PE, so it may help make the credible risk of exposure.
Right. So high risk of morbidity with a PE outweighs the low radiation exposure risk to the baby. Okay, good. All right, so which patients should get anticoagulation therapy? Obviously someone with an acute embolus, right? And then you'll do the adjusted dose anticoagulation. And there is some data suggesting that a full dose treatment for 3 to 6 months after that, you could kind of moderate the intensity of the anticoagulation, but it's not necessarily proven to be safe or without risks of doing it that way. Women with a history of thrombosis, the risk is higher if they have recurrent thrombosis, right? So, I mean, if they had a clot after, an isolated event, which would be like, they broke their leg and then they were sitting on a plane or something like that, that would be different than if they keep having recurrent thrombosis, right? Women with mechanical heart valves, and then women with thrombophilias are increased risk as well. Okay, so this is the table I was talking about. Honestly, it's hard for me to memorize these, so I always go back and look at it. So as long as you know where to find the information, it's helpful. So if you can see up at the top there, if there's no history of embolism, no thrombophilia, you just gonna watch. You're not gonna do anything. If she had a DVT or PE in pregnancy, then you're going to do treatment, right? And then where it gets, a little bit more, let's say when you go down, so history of single unprovoked VTE, no identified precipitating factor present, includes prior embolism in pregnancy or associated with hormonal contraception, and they're not currently on long-term anticoagulation. You could give prophylactic, intermediate dose, or adjusted dose, in pregnancy, and you would continue for 6 weeks after. And then you see below that, there's a low risk thrombophilia without prior embolism. You would actually monitor without any prophylaxis in pregnancy and postpartum. So just so you know that there's this table, and just to refer to it. And this is the continuation here. As you see that you get higher risk. So 2 or more episodes of embolism, you're looking at intermediate dose in pregnancy, still with 6 weeks postpartum dosing. And then if you have 2 or more episodes and are already on anticoagulation therapy, you're going to do the adjusted dose. And then after delivery, you resume the anticoagulation therapy that they were on. So like as we discussed, most women who were on anticoagulation before will need to continue through their pregnancy and postpartum. And there are, the most common ones you know of are heparin, Lovenox, right, low molecular weight heparin, warfarin, and we'll go through that. Yes. Oh.
Have you seen direct 10A inhibitors being used in pregnancy?
Like the oral ones? Yeah. So it's not really recommended in pregnancy and with lactation. I'll get to that later, but yeah. So with the heparin compounds, neither the unfractionated heparin or low molecular weight heparin cross the placenta. They are not teratogenic, so they're safe. They don't cause fetal anticoagulation. Both work through inactivating the factor 10A via antithrombin 3, ultimately inactivating thrombin, preventing conversion of fibrinogen to fibrin. You see this here. So unfractionated heparin, it is isolated from porcine and bovine intestines. So that's important if you have patients who, Hindu or Sikhs or Muslim. That's something to just be aware of and counsel and something to consider. It is metabolized by the liver, excreted in the urine. It can be administered IV with quick onset of action, and half-life is about up to an hour. So compare that to low molecular weight heparin, or like Lovenox, for example. And these are also a list of other types. So Lovenox advantages over just regular heparin. It's more predictable in its anticoagulation response. So it doesn't require routine monitoring with all the lab testing. So therefore, it's easier for patients to administer. It has a longer duration of action, so you can dose it once or twice a day outpatient. There's fewer bleeding episodes, lower risk for heparin-induced thrombocytopenia, lower incidence of osteoporosis, which can occur if you have been treated for more than 6 months. And so for all those reasons, or for mainly just that it is easier to dose and you don't have to do all the lab testing, we usually recommend Lovenox over heparin in pregnancy. Some disadvantages is a slight delayed onset of action. Because of the longer duration, it's difficult to stop. And it's less easily inactivated with protamine sulfate. And if you do have to monitor it, you get the anti-factor 10A activity testing, which may not be available in all labs. Also, maybe more skin reactions at the injection site. So, and then heparin advantages over Lovenox, it's less expensive. We kind of talked about some of these already. You can use it in patients with renal insufficiency. And disadvantages, it's a narrow therapeutic window. You need the frequent lab monitoring, and then heparin-induced thrombocytopenia is more common. So here you can see these are the dosing. So for table 2, you have the prophylactic dosing for Lovenox would be 50 milligrams sub-Q once daily. And then you'll see if you were to do the adjusted dose or therapeutic dosing, it would be 1 mg per kg every 12 hours. Okay, and then compared to heparin, you're going to actually adjust it based on the trimester for the prophylaxis. And then for the therapeutic, it's 10,000 units Q12. And then the whole reason that you monitor with the lab testing is you need to make sure that the PTT is in the target range of 1.5 to 2.5. Okay, so warfarin, we don't commonly use warfarin a lot. Do you know the reason? Yeah, so so warfarin exposure for the fetus at 6 to 12 weeks can cause warfarin embryopathy, including facial defects, cataracts, cardiovascular anomalies, hydrocephalus, and then the epiphyseal stippling that we always get pimped on or something. So in women with mechanical heart valves, the risk of thrombosis is very high. So for those women, you would actually still want to continue. What you can do is switch to Lovenox during that 6 to 12, 13-week period, and then switch back. But definitely you would need a multidisciplinary team to help you with this. And then something to be aware of, there would be higher risk of bleeding at delivery, and the neonate may need vitamin K or FFP. So these are the other ones that you had asked about, the oral direct thrombin inhibitors and the anti-10A inhibitors. So because there's insufficient data in pregnancy and lactation, we don't recommend it right now. So other things to think about when you're dosing and just thinking about the therapies, physiologic changes in pregnancy. You have this 40 to 50% increase in maternal blood volume, increase in glomerular filtration rate and renal excretion of the heparin compounds, increased protein binding of heparin. So all things to consider. Now, this is the one that we're always, discussing, right? And trying to look up and discuss with anesthesia, but timing of delivery and anesthesia. So looking back to when we were comparing Lovenox and heparin, which therapy, if somebody was a patient on heparin versus a patient on Lovenox, which one would require, I guess, maybe a little less advanced planning? Like if they were to come in, in labor and wanted an epidural. Heparin, right? Yeah. So I don't see it done here as much, but in my program, when we had patients on Lovenox and around 36 weeks or so, we would actually switch them to heparin for, the thought being that if they came in active labor and they want an epidural, they wouldn't have to wait that long after the last dose for them to be able to get it. So anyway, with Lovenox prophylactic dosing, you would want to have the last dose at least 12 hours before scheduled induction of labor or C-section. If they have therapeutic dose, you want 24 hours, the last dose would be 24 hours before. For heparin, 7,500 BID or more, you want the last dose 12 hours before, and you want to check your anticoagulation status with the labs. And then if anybody, especially if they needed to be on therapeutic dosing and you have them off of it, ideally you want them admitted and then either start the induction right away and get them delivered so that you minimize the time that they're off their anticoagulation, and then keep the SCDs on until they're able to get up and walk around, or you can resume the anticoagulation. Okay. So this is another good table. And you can see kind of just summarizes what we already talked about. And then in terms of when in terms of the timing of when to take the epidural out, you want, for example, for the heparin prophylaxis, you want to wait at least an hour after the catheter has been removed before restarting the heparin. With the Lovenox, you want to wait at least 4 hours after the catheter is removed to restart. So how long do you continue anticoagulation postpartum, prophylaxis postpartum? So generally it's about 6 weeks. As for the high-risk patients or who have a significant high risk that after delivery. And, that may also be obesity, immobility. And then in general, the dose and the route and everything will vary based on the indication for the anticoagulation. So we kind of already went over this with the last table. And that's it. Any questions? No? Okay.